of 9 in boys. But again, early puberty can be addressed. It can be treated. So for the type 2 diabetes mellitus, it has been seen that children who are obese have tenfold risk of developing type 2 diabetes mellitus. And global data shows that 75% of pediatric type 2 DM cases are obese. In 2021, there were about 41,000 new cases of type 2 diabetes mellitus among children and adolescents who were obese. And of course, the incident varies from 200 to 734 per 100,000 population, depending on the country of origin. Now, the diagnosis of type 2 diabetes in children, I'm sure everyone is familiar with this. The diagnosis of type 2 diabetes in children is the same as the diagnosis of diabetes in adults. We both use the same criteria, HbA1c greater than or equal to 6.5%, a fasting plasma glucose greater than or equal to 126 milligrams per deciliter, and or 2-hour plasma glucose of more than or greater than 200 milligrams per deciliter during an OGTT. However, it is quite difficult to perform an OGTT in children, so we are satisfied with just demonstrating a random plasma glucose greater than or equal to 200 milligrams per deciliter. Of course, this this can occur in the presence of symptoms of hyperglycemia like polyuria, nocturia. However, because we're dealing with obese children, you don't appreciate the usual weight loss that we see in patients with type 1 diabetes. And it's also important to point out that even patients or children with type 2 diabetes may present in diabetic ketoacidosis, which is a very catastrophic condition. How about diagnosis of prediabetes or insulin resistance in children? It is diagnosed based on any of the following scenarios. So an HbA1c less than 6.5. So it's between 5.7 to 6.4. A fasting plasma glucose between 100 to 125 milligrams per deciliter, or a 2-hour postprandial glucose during OGTT at 140 to 199 milligrams per deciliter. But if you don't do an OGTT, plasma glucose less than 200 is already considered an evidence of insulin resistance or a pre-diabetic state. In countries where insulin assay is readily available, or where you are very scientific about it, then you determine your HOMA, your homeostatic model assessment model, insulin resistance index. You multiply your fasting serum insulin with your fasting plasma glucose and divide it by 22.5. The normal should be between 1 to 1.9. 2.9 is suggestive of early or mild insulin resistance, while a HOMA index of 3 or higher signifies insulin resistance. But as I mentioned, there are areas where insulin assay is not available, so we get a surrogate marker of insulin resistance, which is very evident on physical examination. Look for acanthosis nigricans, which is a hyperpigmentation in the nape, in the armpit, and even in the interdigital areas of a patient. So in fact, insulin assay is not a prerequisite in the workup for patients who are obese. So the question now is, when do we screen obese patients for insulin resistance and type 2 diabetes, especially so when most of them can be asymptomatic? One is children 10 years and older who are overweight. We should evaluate for abnormal glucose metabolism and liver function in the presence of risk factors of type 2 diabetes mellitus. And what are the screening tests recommended? Just a fasting blood sugar and HbA1c. And what are the risk factors that you should consider that should strengthen your desire to do further studies or screening for these obese children. One is family history of type 2 diabetes, a history of gestational diabetes, signs of insulin resistance such as acanthosis nigricans and PCOS, which is common in adolescent girls, and use of obesogenic psychotropic medication. So in the history taking, you have to ask, because we know that mental health is very profound or common these days. So we have to ask whether these obese kids are on obesogenic psychotropic medications like your antipsychotic drugs and your antidepressants. It has been found that there is a very good association between risk factors and the prevalence of dysglycemia. When we say dysglycemia, it encompasses both pre-diabetic state and a true diabetic state. And the ADA, risk-based screening, shows that if there is one risk factor, there is a very high prevalence of type 2 diabetes, that's 23.1%. But if there are 4 risk factors, the prevalence of insulin resistance and type 2 diabetes rises to almost 45%. So this, I just want to show here the association of the risk factors, your family history of type 2 diabetes, maternal GDM, dyslipidemia, and fatty liver in the occurrence, in the development of insulin resistance and type 2 diabetes. So you can see here that there is almost two times risk if you have a family history of type 2 diabetes, almost a 2.5-fold risk if you have dyslipidemia, or if you have maternal GDM, it is the risk is tenfold. And if your patient has fatty liver, the hazard ratio, again, it's almost similar to odds ratio, is almost 2. Now, if we look at recommendations for various groups on detecting insulin resistance or diabetes mellitus in pediatric population, you can see here that it's almost the same as what I've mentioned in the previous slide. It has to be emphasized that fasting insulin is not recommended for diagnosis, but because of the epidemic of obesity, size is no longer a very good discriminating point between type 1 and type 2 diabetes. Years before, we used to say that type 1 is associated with lean body mass, whereas type 2 is associated with obesity. But these days, because of the epidemic of obesity, because of the obesity epidemic, we now see a lot of patients with type 1 diabetes who are obese. So the only way, if we're confused, one of the things that we usually request as endocrinologists to differentiate type 1 from type 2 diabetes is to request for pancreatic autoantibodies. The presence of 1 or 2 antibodies like the GAD antibodies and your anti-insulin antibodies will be in favor, if they're present, will be in favor of type 1 diabetes mellitus. How do you, now, if your patient tested negative, how do you retest your patient? During initial testing, the patient passed the test. The patient is not pre-diabetic or does not have type 2 diabetes. So how frequent should we repeat the test? So if your patient's HbA1c is 5.7 to less than 6%, but there are risk factors, one or more risk factors present, there is a chance that they will progress into actual type 2 diabetes. So you should repeat testing in 12 months. So the general pediatrician can do this. At this point in time, you don't have to refer the patient to the specialist. So that's for the type 2 diabetes. What's another metabolic consequence of obesity? One is hepatic consequences. It used to be that the liver disease associated with obesity has been referred to non-alcoholic fatty liver disease, but the nomenclature has changed. It is now metabolic dysfunction associated liver disease, your muscle. This was updated in 2023 to reflect the metabolic basis of the disease and to reduce the stigma associated with the term non-alcoholic. It encompasses a spectrum of liver pathology, and it is very important that you monitor these patients because the progression to cirrhosis is a risk factor for later development of hepatocellular carcinoma in adulthood. So metabolic dysfunction associated liver disease is actually the most common chronic liver condition in children and adolescents nowadays. So the prevalence rate is about 59% in pediatric populations with severe obesity, and there is a 26 times likelihood of developing fatty liver disease in patients who have very severe obesity. You know that obesity in children is graded into grade 1, grade 2, and grade 3. Grade 3 being the severe form of obesity, and we base it on the percentage above the BMI percentage above the 95th percentile. So if your BMI is more than 140% of what is to be the BMI at the 95th centile, that's severe obesity. So what do we do to test for muscle? It's very simple, just a single test. Your ALT, your alanine transferase enzyme. So if during the initial testing your patient's ALT is not affected, you have to repeat it in 3 to 6 months. If ALT is abnormal at twice the upper limit of normal or greater, which is for males, it's greater than 52, and for females, it's greater than 44 international units, then you have to repeat your test in 3 to 6 months. After a second abnormal ALT result, there is already a limited guidance. So if there is a second abnormal ALT result, what do? We refer these patients to our hepatologists or our gastroenterologist colleagues. For children with persistently elevated ALT levels at twice normal and/or risk factors for progression are present, it may be reasonable to repeat your ALT every 6 to 12 months. Now, the next question is, do we do ultrasonography in all patients who are obese? Is it really very helpful? It has been found that ultrasonography alone is unable to determine and quantify the amount of liver steatosis in children with reliable accuracy, and thus is not recommended. It can be helpful to exclude anatomical abnormalities or evaluation for portal hypertension, but by this time, then you should have physical examinations indicative of portal hypertension. You can consider that ultrasonography with transient elastography to measure the level of stiffness within the liver, which is a correlate for liver fibrosis. Other imaging studies that you can do, of course, in resource-limited areas, you cannot do these things immediately. So CT scan is not an ideal imaging modality because of increased exposure to radiation, and MRI with spectrography can diagnose and track steatosis over time. So this can be done in more progressive countries or where financial constraint is not an issue. So this is just to validate what I said earlier, that most societies, this is Taiwan Society for Pediatric and Gastroenterology Hepatology Association. So you can see here that routine ultrasound is not recommended by NASPAGAN, but for the Taiwanese, they favor liver ultrasound to improve diagnostic accuracy. But for the American Association for the Study of Liver Disease, serum ALT remains the recommended screening tool. So for us in the Asia Pacific region, we are glad to know that ALT is just enough to screen for liver problem. How about renal impact of obesity in children? Although one author found an association between overweight and obesity, it occurs in later life. So these are the common renal injuries brought about by obesity. It leads to hyperfiltration injury, it causes proteinuria, it causes FSGS, and it can progress to CKD. But luckily, these renal problems do not occur until they go into adulthood. And so the question is, should routine screening be done to detect kidney disease? And is there a routine screening test that can be done? Fortunately or unfortunately, there is no evidence that was found on the effectiveness of routine screening to detect the risk of kidney disease. And in the available studies, there was no significant difference in renal parameters between those who are obese and overweight and those who have normal weight. So as of the moment, there are no longitudinal studies that have investigated renal function trajectories on the incidence of kidney disease among children or adolescents. And we recently completed a PPS CPG and obesity in children and adolescents. And we really have gone through the literature and found no studies citing routine screening for kidney disease. But kidney disease could occur as a result of the other metabolic consequence like the type 2 diabetes. Another important thing that we shouldn't overlook is the psychosocial impact of obesity. We have to address the stigma and psychosocial factors. It should take precedence over weight loss. Children who are obese, especially those who are extremely obese, have been found to have low self-esteem. They have persistent body dissatisfaction and lack of confidence. Because of weight stigma, they experience peer bullying and social isolation, which can lead to chronic stress. And it can even lead to mental disorders. They've found that there is about 2% risk of obese patients developing mental disorders. And this also leads to poor quality of life. Another important consequence of obesity is the increased risk for tumor development, but it occurs in adulthood. So this is the explanation for this. You know that obesity is a situation where you have meta-inflammation, you have production of your cytokines, which can cause adverse effects on cellular function and could place these patients at risk for tumor development in adulthood. Scare 3, what's the third source of scare? What we term the preventable crisis. If you look at this diagram, in the systematic and meta-analysis review done that I cited in my previous slides, they have found that these are some of the factors associated with childhood obesity. And so if you want to, you have to prevent this childhood obesity prevention should address these issues. You know that breastfeeding is a protective factor against obesity. They've found that vaginal delivery has protection over obesity. The reason for this is you know that your gut microbiome may be altered with CS delivery. And of course, it is important that preconceptionally, the expectant mother should already be healthy, that she should be free from diabetes, she should be screened for diabetes. We know that regular physical activity is one of the preventive measures. Adequate sleep is important, limiting screen time, training of healthcare providers, and promoting healthy habits. It is easier said than done, but because of the competition, because of the exposure to television, these children are exposed to commercial products which are unhealthy. Intake of ultra-processed products, as mentioned by Dr. Connie earlier, is very rampant. So this is very challenging. That's why I call it crisis. Another important issue is for pediatricians. The best prevention for all these complications is prevention of obesity. And a very simple tool that we emphasize in our lectures is the use of our growth charts. If primary healthcare providers just make use of the growth charts, plot the weight and height of the patients at least every 3 months, then we catch patients who are already traversing the unhealthy path. So I think that's the only important message perhaps that I will let the group retain, share with the pediatricians. Please do measurements and plot them in appropriate growth charts. So in the primary drivers of obesity, of course, is diet and lifestyle. And a lot of studies have been done, a lot of diets have been done, but you know, the results of diet and lifestyle intervention is very dismal. Although there is improvement because of pharmacotherapy, we try to avoid pharmacotherapy in children as much as possible. So the perfect storm for obesity has to address these things. We also have a lot of endocrine disruptors. So the environment is so difficult to fight. So the government should really take effort to address this obesogenic environment. So development, environmental chemicals, nutrition, stress are all there. So how can we even address these issues? So there's really a crisis as far as prevention is concerned. So if there is already stress on metabolic system, like consumption of fat and sugar, again, this is a lifelong habit. So lifestyle eating habits should start at birth, during the early life. Kasi at this time, we rarely see children eating vegetables. So continued exposure to the environment. So this is the perfect storm for obesity and subsequent complications. So if we don't address this, then our fight against obesity and its consequences is moot and academic. So I would like to summarize my talk by saying that obesity is a source of scare because of unabated increase in prevalence. It is associated with complications which can initially be silent, but leads to a chronic progressive disorder and may run into adulthood. Preventable crisis is a reality since preventive measures need to be started from conception, healthy lifestyle habits from birth to adolescence, and lack of effective health policies. So thank you for your attention, and everybody really needs to act if we have to curb obesity and its consequences. Thank you very much.
Um, Thank you very much, Dr. Professor Lorna Bud, for walking us through the childhood obesity scare that raises alarm about metabolic consequences that may produce cardiovascular, hepatic, kidney, as well as health, weight stigma, and mental health disorders. For our next topic, let us all welcome Professor Masood Sadiq. He will be talking about recognition and screening of hypertension in children. Professor.
You are muted, Professor.
Okay.
Yeah.
Can you hear me now?
Yes, thank you.
Okay. Let me first thank the Philippine Pediatric Society as well as Asia Pacific Pediatric Society for asking me to share my thoughts as well. Recognition and screening of hypertension in children. I think childhood hypertension is increasingly common. We know that up to 3% of general pediatric population now have hypertension. But when it comes to overweight children, and we just heard about that, up to 7.4%, and 50% of children with chronic kidney disease and diabetes mellitus also have systemic hypertension. But the problem is that it's often silent, missed, and underdiagnosed. We know that blood pressure tracks from childhood into adulthood, and early end organ damage can begin in childhood. So when it comes to Asia Pacific region, I think we are facing a rapid lifestyle transition in majority of the countries within the region. We are using high sodium diets, urbanization, rising obesity and metabolic syndrome, variable healthcare access, and of course, prevalence in some countries of up to 15%. So my talk will be covering magnitude of the problem, epidemiology, prevalence trends, and regional burden, definition and classification of hypertension, how to accurately measure blood pressure, technique of sizing oscillatory versus oscillometric and white coat effect, screening who, when, and how we should be doing that, secondary hypertension and what are the clear red flags, what are the fundamental principles of prevention, and where we lack in terms of Asia Pacific region in terms of gaps and call to action. So let me take you one by one through these important contexts. I think when it comes to magnitude of problem, prevalence of hypertension in certain parts of Asia Pacific region, and this is a pool data for 2023, is anywhere from 14 to 22%. There's an increase in childhood hypertension prevalence across Asia Pacific region over the last 20 years. The data from 20 years ago and today, there's a significant rise in terms of recognition and prevalence of hypertension. And 75% of these affected children, unfortunately, remain undiagnosed. That's why we label it as silent epidemic. And 25% of adult hypertensives have hypertension, which was detected as a child. The fundamental context of tracking, we know that blood pressure in childhood tracks strongly into the adult life. And I think early hypertension really predicts adult cardiovascular disease events as well. And target organ damage is again something which begins very early. I think one other important factor is the cognitive impact of hypertension. We know that childhood hypertension is associated with reduced working memory, academic performance, but the most important thing here is that majority of the times it's preventable. Now, look at the Asia Pacific regional data. You can see Japan has one of the lowest, like 8%, India 9%, South Korea, Philippines and Pakistan has almost similar prevalence as recorded in literature. Of course, China has a slightly higher one, particularly in urban China and Pacific Islands. You can see significantly higher reason. But what are the key drivers? If we look at the regions wise, in China, there is a very rapid urbanization, high dietary sodium, and sedentary lifestyle with rising obesity. Philippines and Pakistan has very similar context because nutritional transition, processed foods, limited pediatric blood pressure screening programs all contribute to this magnitude. India, of course, a large rural population where it is underdiagnosed. We know that the Indian food has a salty diet, low screening awareness among general practitioners. If you look at the relatively developed countries like Korea, then stress is an important factor. Of course, ultra processed foods, rising adolescent metabolic syndrome. But if we look at Pacific Islands, I think there is some element of genetic susceptibility as well, in addition to high sodium traditional diet or obesity epidemic. In Australia and New Zealand, which are developed countries, I think over there the indigenous population seems to have a significantly higher risk of hypertension as compared to the rest. And of course, the socioeconomic disparities dominate this factor. How do we define hypertension in pediatric age group? I think this is an extremely important context for pediatricians. We define hypertension as systolic or diastolic blood pressure above 95th centile for sex, age, and height on 3 or more separate occasions. And if we look at the American Academy of Pediatrics criteria, it divides it into elevated blood pressure or pre-hypertension, which is between 90th and 95th centile. And then you have stage 1 or stage 2 hypertension, which obviously is different for children who are above 13 and above, and those who are under 13. So systolic blood pressure and or diastolic equal or more than 95th centile, but below the 95th centile plus 12 millimeters of mercury. And similarly for stage 2 hypertension, it's more than 95th centile plus 12 millimeters of mercury. I must admit that I find this hypertension definition a little confusing, actually. But what I personally use and what I would recommend is the 4th report from National High Blood Pressure Education Program, which was published in Pediatrics in 2004. I find this very reasonable and easy to understand. Normal blood pressure is below 90th centile, elevated is more than 90th but less than 95th centile, or of course 120/80 if it's lower than 90th centile. And stage 1 is from 95th to 99th centile plus 5, and stage 2 is more than 99th centile plus 5. It's fairly easy to understand, easy to calculate. And I think, of course, if you're above 13 years of age, then for stage 1, it's 130/80. to 139/89, and for stage 2 it's 140/90. So anything more than 140/90 would obviously fall in stage 2 category as per this definition. And you can see how we are going to go for clinical action and how do we go for follow-up on all these age groups or these categories. If we look at the regional considerations, and both American Academy of Pediatrics as well as European Society of Hypertension percentile tables, there are certain things which need to be mentioned. Like in China, blood pressure normative references established for 119,000 children aged 6 to 17 years, values at 95th centile are systematically lower than the American Academy of Pediatric tables. And I think this is very important context. That's why we need to have our own tables for every region or for every community. And I think if we use American Academy of Pediatric tables, then we will be underdiagnosing hypertension in Chinese children. Similarly, if you look at Indian children, they have lower birth weights and higher visceral adiposity at equivalent BMI. So hypertension risk occurs at lower BMI threshold. And I think Indian Academy of Pediatrics has already published Indian specific blood pressure reference data. If you look at Korean children, they show lower average blood pressure than US counterparts at equivalent BMI. And I think these tables, European tables, may overclassify particularly the mild elevations. If I look at my own country, I think it is our National Health Survey of Pakistan, which was done between 1990 and 1994 by PMRC under technical guidance and support of US NCHS. What we found was that Pakistani children have higher body mass adjusted blood pressure than white children in USA. And this was a nationally representative sample of 18,135 individuals between 6 months to 110 years. And this is the data which was published from my own country. Analysis performed on 5,641 Pakistani children between 5 and 14 years. And this was a nationally representative National Health Survey of Pakistan data. And the overall prevalence of high blood pressure was between 5 and 14 was 12.2% and 15.8% in boys and girls. So mean was 12.2, higher in boys than it compared to girls. And this is in sharp contrast with the predicted 5% prevalence of high blood pressure in children in United States. So I think what this highlights, and you can see this over here, this is a BMI specific blood pressure data in children from Pakistan versus white children in the United States. And you can clearly see how this data is different, particularly when it comes to diastolic values. Over here, there's a clear gap between the NHSP data and the data from European or American children. So I think one of the important fundamental understanding over here is that we need to have our own data. We need to have our own tables to really label anybody as hypertensive. Just to remind pediatricians, what are the normal blood pressures for children? And of course, we know that it varies by age, gender, and height, and it ranges from 60 to 110 to 120, depending upon which age group we are looking at. And I've given these values over here, but I think one of the simplest things to remember is that when you are born, your blood pressure is generally 60 systolic, and diastolic would be 30 or 40. Then your maximum rise of blood pressure in your life occurs in first month of life, because you rise by 1 millimeter of mercury every day. So by the time you are 1 month of age, it has gone up to 90. And it generally stays between 90 and 100 for the first 2 years of life. And then generally there is a 1 to 2 millimeter mercury rise every year until you are 13, when you achieve your adult blood pressure levels, which are 120/80 mean, depending upon which part of the country or which part of the region you are. And I think this simplification, I know it's a slightly oversimplification, but it makes life easier for a pediatrician sitting in a general practitioner or sitting in his own clinic, because then he can easily make out when to refer these children to a specialist. One of the major problems when we are doing blood pressure in children is accurate measurement. And I think the most critical step in diagnosis, because most errors are made before the cuff is actually inflated on a child. I think preparation is important. The child needs to be seated quietly, no caffeine, exercise, or smoking in prior 30 minutes, empty bladder, no talking during measurement, and needs to be comfortable in a room temperature. The back needs to be supported, both feet flat on the floor, never dangling. I think that can raise your blood pressure. And right arm at heart level, totally unconstrained. Remove tight clothing if you have any on the arm. And of course, the bladder length must cover 80 to 100% of arm, and width should be minimum 40% of arm length. The more, the better. And I think we know that if it's too small, you will get a reading which is falsely high. And if your cuff is too large, then you will get a reading which is falsely low. And I think oscillatory method is the gold standard. Of course, oscillometric validated devices are acceptable, and I will talk about that in a moment. You take minimum 2 readings, 1 to 2 minutes apart, and average both reading. If I think more than 5 millimeter difference, take a third one as well, and record actual value and do not round it up. And I think then you can plot it on age, sex, height, percentile child immediately, and you can diagnose hypertension only after confirmed elevated readings on at least 2 separate occasions, if not 3 separate occasions over here. These are the different cuff sizes, and I think every pediatrician should have at least 3 cuff sizes: the neonate, infant child, and an older child. I think I would say 4, but at least 3 different sizes. And you can see how the bladder width and bladder length differs in different sizes that we use in pediatric age group. Of course, a large adult or thigh may also be needed in some of these patients. What are the available devices? I think it's important to remember that these automated, or what we call oscillometric machines, estimate blood pressure based on point of maximal oscillation of the brachial artery during inflation. They are, of course, easy to use. They decrease observer bias. They are helpful when auscultation is difficult, like a screening infant or in an ICU setting. But the problem is validated devices. Please use a validated device. Majority of devices available are not validated for children. So I think it's, unless you're taking it on a 13-year-old or a 15-year-old, then you can use an adult validated device, but you must make sure that it's a validated device. And I think as systolic blood pressure measured by this device is higher compared with readings obtained by auscultation up to 10 points. So I think American Academy of Pediatrics recommends that blood pressure readings more than 90th centile with an oscillometric device must be reconfirmed by auscultation. And we know that the auscultatory devices available are either manual auscultatory devices or aneroid sphygmomanometers. Since the mercury sphygmometers are no more used in pediatric or in clinical settings, so I think we must learn how to use an aneroid sphygmomanometer, because they have replaced mercury manometers for manual blood pressure. And it consists of an inflation bulb, as you can see, and a manometer that is connected by tubing. And instead of using a mercury column to determine blood pressure, I think the anaerobic manometer has a dial that contains delicate, intricate mechanical parts. One of the important things here is that when you are inflating the bulb, please do it quickly. When you are deflating, then you go slow. But when you're doing inflation, I think the recommendation is that that should be done fast so that there are minimum errors here. So accurate blood pressure measurement, one of the crucial things, I think most common error in clinics, it's critical that the blood pressure is, if your cuff is too small, you will overestimate. If it's too big, then of course you can underestimate. Similarly, I think oscillometric without auscultatory confirmation can also lead to an error. And I think single visit diagnosis is again, which can lead to white coat hypertension and accounts for up to 30 to 40% of elevated readings, which we see in pediatric clinics. I think a failure to correct for height, measuring only one arm, are the other mistakes which need to be obviously avoided in these patients when you are measuring blood pressure. Ambulatory blood pressure recording is something which most people will consider as a gold standard for confirming sustained hypertension and excluding white coat hypertension. So what are the indications? I think any suspected white coat hypertension, suspected masked hypertension, normal clinic and organ damage or symptoms, all children before initiating antihypertensive pharmacotherapy, evaluation of treatment efficacy, chronic kidney disease, assessing nocturnal dipping status, children with diabetes, type 1 diabetes detection for masked hypertension, and of course, in all high risk children. I think what is important is that your mean 24-hour blood pressure should be less than 95th centile or with a normal nocturnal dip, which is 10 to 20%. And of course, elevated clinic BP, but normal ambulatory blood pressure monitoring, you do not need to treat these children. They only need a lifestyle advice and follow up. But normal clinic BP, but elevated ambulatory blood pressure reading, consider high cardiovascular risk and treat them as true hypertensive patients. But if it's obviously elevated both clinic and ambulatory, then you are dealing with true hypertension, which requires treatment. Non-dipping pattern, a nighttime blood pressure for less than 10, I think this could be associated with chronic kidney disease, obstructive sleep apnea, and high cardiovascular risk diseases. So this needs to be considered whether you are getting that or not. And of course, elevated nighttime blood pressure is common in children with chronic kidney disease, diabetes, and is an independent cardiovascular risk factor. So what is the screening strategy? I think the American Academy of Pediatrics in 2017 has recommended that all children aged 3 years or less, these are the infants and toddlers, I think they should be targeted screening only. So I think if there is a, we can go to the high risk slides shortly, but this is a targeted screening. But all those children who are between 3 and 5 years at every annual well child visit. 6 to 12 years, annual blood pressure at every routine visit. 13 to 18 years, annual blood pressure at every routine visit must be done. But I think the practical protocol will be you measure right arm blood pressure, record actual value plus cuff size in growth chart, and of course, electronic medical record. Use American guidelines if you don't have your local guidelines. If you have your local ones, of course, go by that. And of course, that requires age, sex, and height measurements. And then you can classify these into 4-tier classification as normal, high blood pressure, stage 1, stage 2. And obviously your action will be dependent upon in which category you are getting them. When it comes to high risk children, and I think I have put conditions here which obviously are considered as do not wait until age 3. If you have congenital heart disease, coarctation, cardiomyopathy, I can remember many children who were labeled as cardiomyopathy who actually had hypertension as the etiology of hypertension once we did a detailed evaluation on those patients. Obesity, type 1, type 2 diabetes, hyperaldosteronism, Cushing syndrome, congenital adrenal hyperplasia, family history of premature hypertension or cardiovascular disease, neurofibromatosis, tuberous sclerosis, Williams syndrome. These are all high-risk children. Similarly, I think renal conditions like chronic kidney disease, single kidney renal anomalies, recurrent UTIs, history of hematuria, proteinuria, history of prematurity, low birth weight, or NICU admission, solid organ or hematopoietic stem cell transplant, and various medications like particularly steroid stimulants and NSAIDs, calcium inhibitors. One thing which we often overlook is obstructive sleep apnea. I think this is an independent predictor of masked and nocturnal hypertension in children and should be considered for ambulatory blood pressure monitoring in all obese children. We heard an excellent talk on obesity, and I think this is something which we must go by. Just to remind everybody, we see pediatric hypertension in two categories, primary and secondary. And I think primary is the most common cause of mild hypertension. If you see mild hypertension, think about primary hypertension. But I think if you see significant persistent hypertension, always look for a cause in pediatric age group. Of course, primary hypertension is most common, older children, strong family history, combination of genetic and environmental factors. And secondary hypertension obviously has a huge list. I just went through it earlier on as well. Renal being the most common, renovascular, cardiovascular, endocrine, neurological, and of course, drugs and chemicals are all important causes. So how do we go about secondary hypertension? What are the clinical clues to secondary cause for a pediatrician? You can see the etiology on your left of your screen. Essential or primary hypertension being the most common form, but renal etiology is the most common cause of secondary hypertension in children. Renovascular, endocrine, coarctation, other cardiac medication. So, what are the clinical clues? Age less than 6 years, always think secondary. Stage 2, at any stage, think about secondary. Abdominal or flank bruit, renal artery stenosis. Difference between upper and lower limb, coarctation of aorta. Hematuria, proteinuria, renal parenchymal disease. Moon phase, tria and obesity, Cushing syndrome. Low potassium, muscle weakness, primary hyperaldosteronism. Sweating, palpitation, headache, think about pheochromocytoma. And of course, if you see cafe au lait spots, think about neurofibromatosis. What should a pediatrician be doing as a first stage to diagnose hypertension? The first and foremost is urine analysis, urine culture. Of course, urine protein creatinine ratio, serum creatinine, electrolytes, extremely important, fasting lipid profile, glucose, HbA1c, full blood count. Renal ultrasound is a compulsion. 30% of these patients have a renal etiology. And I think the size, discrepancy, echogenicity, and echocardiogram obviously again is a must, because you will not only be diagnosing an underlying pathology, but also looking at end organ damage, most sensitive end organ damage marker. Of course, if you suspect a secondary cause, then the list expands significantly. Plasma renin, aldosterone, 24-hour urinary catecholamines, morning serum cortisol, thyroid function, renal Doppler ultrasound, CT, MR angiography, and of course, sleep study if you find a Down syndrome or an obese patient. Management of principles are not I think, the domain of this particular presentation. So I will only be going very quickly just to give you the fundamentals, because treatment intensity is guided by blood pressure staging, secondary cause, and presence of target organ damage. Lifestyle modification, of course, I think we heard two beautiful talks, so I wouldn't go in details. But of course, encouraging fruits, vegetables, low-fat diet, dairy, limited processed foods. It reduces blood pressure by 4 to 11 millimeters of mercury, less than 2 grams per day, sodium recommended, a minimum 60 minutes physical activity, and 5 to 10% weight reduction where applicable are the simple lifestyle modifications which we should be emphasizing. Of course, pharmacotherapy is indicated for any symptomatic hypertension, stage 2 hypertension, secondary hypertension, stage 1 failing lifestyle intervention, and if you see any target organ damage. And we all know these groups of first line drugs classes in children: ACE inhibitors, ARBs, calcium channel blockers, thiazide diuretics, and beta blockers. I wouldn't go into the details except saying that I think if proteinuria or chronic kidney disease, of course, ACE inhibitors are preferred, but they are contraindicated in pregnancy and renal artery stenosis. ARBs are alternative to ACE inhibitors, used in chronic kidney disease, diabetes, but remember their teratogenic possibility. Calcium channel blockers are well tolerated, excellent pediatric safety, so they are first line for many pediatric hypertensions. So is true for thiazide diuretics, but you need to monitor electrolytes and avoid in hypovolemia. Beta blockers, second line, useful for hypertension with tachycardia, and of course, first line for children with coarctation of aorta. You must also make sure that you look at the target organ damage, because subclinical target organ damage is common in hypertensive children. So left ventricular hypertrophy, echocardiography. I think LVH is reversible with effective blood pressure control. So I think this is important. Carotid intima media thickness, particularly in obese and hypertensive children. I think carotid ultrasound is something which we can easily do. Proteinuria, microalbuminuria, urine protein creatinine ratio, early morning ACR more than 3 milligrams per millimoles is obviously abnormal. And this marks both renal damage and increased cardiovascular risk. So I think this is also drives your ACE inhibitor or ARB choice. And very importantly, obviously, if you see evidence of hypertensive encephalopathy, unfortunately, then of course the test is clinical, but then MRI and CT scan will become very relevant. So to finish off, what are the gaps in Asia Pacific region and how can we call to an action? I think there are no standardized normative tables for many countries. So I think we need to invest in multi-country pediatric blood pressure normative data, and I think that should be something Asia Pacific priority. Limited pediatric blood pressure screening programs in many countries. So I think we should integrate routine blood pressure monitoring into school health and well child programs. Similarly, inadequate cuff size availability. I think we must advocate that pediatricians should have at least 3 cuff sizes standard in all clinics where they are serving pediatric patients. Low clinician awareness also, because many pediatricians still feel that blood pressure does not occur in children. So I think measuring technique, classification, when to refer. And I think device validation is another important context as how to go about it, and which devices should be used. And of course, underutilization of ambulatory blood pressure monitoring. We must expand ambulatory blood pressure monitoring access beyond tertiary centers and task shift where feasible. So in conclusion, and I would like to give a message that I think blood pressure should be measured in every child 3 years or more, annual blood pressure at every routine visit, high-risk children from any age, including infancy. Correct technique is non-negotiable. Right cuff size, child positioned correctly, 2 readings averaged, all oscillometric elevations confirmed auscultatorily. Use age, sex, height percentile tables. Never use adult thresholds for children. Plot on correct table at every visit. Height must also be measured. And confirm before labeling. Putting a child on antihypertensive for the rest of his life is not a small decision. I think we must diagnose over 3 visits. White coat effect needs to be taken away, and consider ambulatory blood pressure monitoring if you're not sure. And always look for secondary hypertension. Children, particularly those who are under 6 years and stage 2, are not primary hypertension until all secondary hypertension causes have been excluded. And I think red flags may mandate urgent workup. Lifestyle first, after appropriately. And I think stage 2 hypertension, secondary cause or target organ damage, of course, you will refer these patients to a pediatric nephrologist or a pediatric cardiologist for treatment. So this silent epidemic is totally preventable. Every child's blood pressure matters. Every clinic visit is a screening opportunity, and early detection is a cardiovascular event prevented. So we must measure blood pressure in every child, correct technique, validated devices. We must classify them on age, sex, and height tables, confirm 3 visits, identify secondary hypertension. And we must act by lifestyle modification, pharmacotherapy when indicate, and of course, we must refer them appropriately. I would close by this Chinese proverb: encased in fat in youth, encased in a coffin in middle age. We shall not let that happen to our children. Thank you very much.
Thank you very much, Professor Sadiq. Again, excellent lecture as usual, very practical, targeted towards a general pediatric practice. And to proceed with our afternoon's lecture, we will now be calling Professor Chen Chikit to give us his lecture on childhood hyperlipidemia. Professor Ching.
Hi, thank you, Sheldon. Before I start, I'd like to thank Dr. Jocelyn Eusebio, as well as Dr. Juliet Valderas for this invitation. And thank you to the organizers for the opportunity to be part of this very interesting webinar. I would also like to thank the preceding speakers for laying the groundwork that kind of facilitates my current presentation fairly easily. Now, my topic is on hyperlipidemia in children. I would like to send greetings from my country, Singapore, and I do not think that the prevalence of obesity in Singapore is that low, but I remain to be proven wrong. I don't have any disclosure to make, but I do have a disclaimer. The current presentation is based on the perspective, my perspective as a pediatric cardiologist from the angle of a preventive cardiology. I am not a lipidologist. I am not an endocrinologist. Part of this talk would briefly go over the lipid metabolism, and we will go over the hyperlipidemia in children in terms of its epidemiology as well as cutoffs. And the question is, why focus on children? We rarely see children suffering from hyperlipidemia acutely in our practice. And then there's a big question that Dr. Juliet has asked me a question about mandatory screening for hyperlipidemia. And last but not least, I will end with the management strategies for hyperlipidemia. To go over the lipid metabolism, I'm not going to go into the details, but suffice to say there are two main pathways, namely the exogenous pathway as well as the endogenous pathway. Now, the exogenous pathway consists of the dietary fat intake consisting of cholesterol as well as triglyceride that gets broken down. And the endogenous pathway involves the production of all these lipids from the liver. Now, what the diagram here depicts is important for us to understand the key players in lipid. For example, we now know that the non-HDL cholesterol is considered a more significant predictor of the presence of atherosclerosis. And it is more predictive of persistent dyslipidemia than just total cholesterol or LDL cholesterol or HDL cholesterol alone. So the non-HDL cholesterol, as the term implies, includes the very low density lipoprotein, the intermediate density lipoprotein, as well as the low density lipoprotein. Now, then there are also the triglyceride-rich lipoprotein, namely the chylomicrons, the very low density lipoprotein, as well as the remnant particles, which includes the chylomicron remnant as well as the intermediate density lipoprotein. I'd like to highlight your attention to the presence of the protein apolipoprotein B. Now, all apolipoprotein bound lipoproteins are proatherogenic. Now, if they are proatherogenic, therefore, there's a risk as the as the atheroma is formed, thrombus can form, and the rupture of the plaque can then result in atherosclerotic cardiovascular disease, for example, myocardial infarction, angina pectoris, stroke, and so on and so forth, which are rarely observed in children, but common in the adult population. So now, why are we then interested in atherosclerotic cardiovascular disease? We as pediatric cardiologists have enough to deal with when it comes to congenital heart disease. And it is very heartening to know that the community within the region is now moving away just focusing on congenital heart disease, but to the wider cardiovascular health promotion. Now, pediatric hyperlipidemia has two main categories of causes, primarily, number one, genetic, as a big group, and number two, the secondary causes, of which obesity or the lifestyle-related dyslipidemia form the majority of the hyperlipidemia. Of course, there are other endocrine causes, for example, hypothyroidism, we have Cushing syndrome, and the use of drugs, for example, steroids, or some of this immunosuppressant like what I use for patients with heart transplant, like sirolimus. Of course, then we will have to then consider the efficacy as well as the need for screening. Are we going to do selective screening? Are we going to do universal screening, which we'll discuss a bit more later, and the treatment that follows after that. And now the treatment are fairly similar to the preceding speakers. For example, lifestyle modification involving dietary intervention, increasing in physical activity in the era of screen time prevalence, and followed by pharmacotherapy. Because if we are able to prevent the formation or minimize or even delay the formation of atheromas or atherosclerosis, we can reduce the risk or delay the development of atherosclerotic cardiovascular disease. Now, this subject matter about obesity has been beaten to death already by the preceding speakers, but this just serves as a heat map to show in the region where are the countries and where are the regions with a high risk of obesity and therefore its associated hyperlipidemia. Now, obesity or being overweight, or also known as a lifestyle-related dyslipidemia, has a particular pattern. Now, this pattern is associated with high total cholesterol and or high LDL, with low HDL and high triglyceride. Now, by just looking at obesity alone, if we were to screen just the obese patients, we will miss quite a number of patients who are hyperlipidemic, because population data have shown 20 to 30% of patients who are, or children who are dyslipidemic, have normal body weight actually, and they may not be obese. And then we talk about the familial hypercholesterolemia. Now, familial hypercholesterolemia forms a smaller percentage or fraction of hyperlipidemia in children. Now, we know that obesity is the most common dyslipidemic pattern seen in childhood, but the importance of familial hypercholesterolemia is to be able to detect them early, because we know that those who are heterozygous familial hypercholesterolemic are at risk of getting atherosclerotic cardiovascular disease earlier than the normal population. And for sure, those with homozygous FH are at incrementally higher risk, even getting atherosclerotic cardiovascular disease within the first or second decade of life. Now, within the familial hypercholesterolemia, there are 3 genes that are commonly affected. Number 1, that's the LDL receptor gene that can have a variant that would form FH, or the gene that encodes the apolipoprotein B, or the PCSK9. Now, all these are packaged into the cells before being extruded after processing. Looking into the Asia-Pacific region, if you look at the countries that have reported the prevalence of familial hypercholesterolemia, we could see that it can range from 1 in 200 to as low as 1 in 500. Now, just to be sure, most of these countries use a clinical definition of familial hypercholesterolemia. Only Japan had molecular diagnosis of familial hypercholesterolemia that was reported. So we have a prevalence of approximately 1 in 200 to 1 in 500, which translates to approximately 0.2 to 0.5% of the population suffering from familial hypercholesterolemia. This is not rare and not negligible. Now, there are cutoffs value by age based on the National Health Lung, Blood and Institute. Now, this table is not for you to memorize. I'm just putting it as out of completion's sake. But there are 2 units that are used which oftentimes cause confusion. Number 1, of course, there's the metric, and of course, then there is the SI unit. They are also age dependent, and we categorize them into acceptable, borderline, and abnormal range. And there are different cutoffs used for children and adolescents versus the young adults. Now, of note, something that I like to highlight is these cutoffs are based on population data, and they are not necessarily data that are correlated with a long-term outcome, particularly related to atherosclerotic cardiovascular disease, because studies that would then look at outcome would need to last way longer for us to be able to establish a significant, reasonable outcome-driven cutoffs. But one, do not memorize the entire table. It's a reference, but there are a few things that we want to look at, what I would consider as actionable thresholds. Number 1, of course, if a patient or a child has an LDL cholesterol of more than 4 millimoles per liter, based on the unit that I commonly use, it should trigger the consideration of testing or even looking for familial hypercholesterolemia. So that's for LDL. When it comes to triglyceride, high triglyceride doesn't just only cause a long-term risk of atherosclerotic cardiovascular disease, but it does cause an acute or a short-term risk of acute pancreatitis. And if it is beyond 5.5 or more than 500 milligram per deciliter, one should aggressively evaluate this as a possible secondary cause, or even treating it to prevent the development of pancreatitis. As I mentioned, we are now looking more into the non-HDL compartment consisting of VLDL, IDL, and LDL. Now, if it is more than 3.8 millimoles per liter, then there's a suggestion that this might be a risk of metabolic dyslipidemia, or another name for the obesity-related dyslipidemia. Now, why are we focusing on children? These are commonly known as adult disease 30 years ago. Now, they are not rare. Lipid abnormalities in children are not rare. 1 in 5 children have been found to have lipid abnormalities based on population data in the US. And for the teenagers, 1 in 4 do have lipid abnormalities. Now, these are alarming, and they're not particularly negligible, to be honest. As the previous speakers have alluded to, atherosclerosis develops way earlier on in life. It develops as early as childhood, based on autopsy studies of children who died from accidents and nothing related to the cardiovascular disease. And autopsy have found fatty streaks as well as atherosclerosis within the aorta. Now, we do know that the atherosclerosis, when they develop in a young age, will progress across the life course. Up till the child hits the teenage years, there might be atheroma, or even in young adulthood forming fibrous plaques. Now, once this gets ruptured, or if thrombus forms and causes complete occlusion, then it manifests as an atherosclerotic cardiovascular disease. Now, when they are not symptomatic, meaning if they do not have myocardial infarction or stroke, then they are considered subclinical atherosclerosis. Now, in the most recent review of the literature, there are more and more interesting findings. When it comes to subclinical atherosclerosis, that's defined as atherosclerosis that is present but asymptomatic, meaning in the absence of cardiovascular disease. It is also found in people without the traditional, what is called cardiovascular risk factors. Now, this is quite alarming, meaning in children who are not obese, in adults who were never obese, or in adults who had normal lipid, there can be atherosclerosis formation. And this is based on multimodal imaging, for example, carotid intermediate thickness, calcium scoring of the coronary arteries, even using markers of endothelial dysfunction to look at aortic stiffness. And using biomarkers, there are presentation of atherosclerosis even in those who are so-called absent of risk factors. And now then this pushes the frontier of preventive cardiology. We are interested in primordial prevention because in the recent era, cutoff values are no longer so applicable because there is a new concept that perhaps what we should target is as low as it is possible. So that's number one. And primordial prevention can prevent development of risk factors, whereas primary prevention would then prevent the development of symptomatic atherosclerotic cardiovascular disease. And secondary prevention is to prevent further recurrence of atherosclerotic cardiovascular disease. Now, in the bottom of this pyramid, one is highly cognizant of the lifestyle factors, which we should then look closely into when it comes to pediatric preventive cardiology. Because in the most recent iteration of the AHA recommendation for cardiovascular health, there is, they call it the Life's Essential 8 that was released back in 2022. Now, this is 11 years after the first release back in 2011, where they call it Life's Simple 7. Now, they added the eighth element into this 7 element initially for cardiovascular health. Broadly speaking, we can divide these elements into two. We can look into health behavior, namely exercise or sedentary lifestyle, diet or poor dietary habit. In the past, we used to call it cigarette smoking, but now we know that number one, it is not just limited to cigarette, but now there is vape or electronic cigarette. Or number two, secondhand smoke exposure also increases the risk of cardiovascular disease. They added an eighth element of sleep and good sleep and a sufficient duration of sleep in children. And the other four are health factors, as presented before: hypertension, BMI or obesity. There was talk about diabetes or blood sugar control. And my element here is looking at the blood lipid. When we come to talk about screening for hyperlipidemia, there are a few things that need to be clear first, so that we are more certain what we talk about when it comes to selective screening. What are we looking for? There are two groups here. Number one, there's a risk factor for dyslipidemia. And of course, then I'm going to show you another set of table that looks at risk conditions. Now, what are the risk factors for dyslipidemia? In the presence of family history with early atherosclerotic cardiovascular disease, namely myocardial infarction, angina, stroke, or any intervention that's required, for example, surgically with CABG stent, or interventionally with stent or angioplasty, or the presence of sudden cardiac death in first or second degree relative, not just first, but extending to the uncles and aunties, including the second-degree relatives in the earlier years, meaning male earlier than 55 years and in females earlier than 65 years. Now, in the presence of this family history, this constitutes a big risk factor for dyslipidemia testing. Then there are high-level risk factors in the absence of family history. For example, the previous speaker, Dr. Masood, talked about hypertension. So if there is hypertension that requires drug therapy or current nicotine exposure, not just cigarette smoking, but also vaping, BMI at least more than 97th percentile, or the presence of any high-risk conditions, which I will show you in a subsequent table. These are considered high-level risk factors for which then screening would be warranted for sure. Then there are moderate level risk factors, meaning they are hypertensive but may not require therapy. BMI that may not exceed 97th percentile but more than 95th percentile, or a low high density lipoprotein cholesterol, and the presence of any moderate risk conditions. Now, what is not in this particular table is the group of population who are also at higher risk, who are the childhood cancer survivors. Now, the reason I can't fit them into either side is because it's dependent on the dose of the anthracycline that they received, the presence of chest irradiation, even bone marrow transplantation. In the presence of high-dose chest radiation, high-dose anthracycline, or even bone marrow transplantation, they fall into the high-level risk factor category. The lower dose radiation or anthracycline cumulative dose would then belong to the moderate level risk factors. Now, then what are the special risk medical conditions? Now, these are the patients in whom screening would definitely be warranted. Patients with diabetes, be it type 1 or type 2, any patients with kidney disease, chronic kidney disease, or end-stage kidney disease, or post-kidney transplant. Like my patients whom I follow up for heart transplant, they are always screened for lipid and they are placed on statin early. And any patients with Kawasaki disease who are still having coronary artery aneurysm should be screened for hyperlipidemia. This is because they are at risk on top of the aneurysm causing clot formation. Then, of course, atheromatous plaque formation would also complicate matters. The moderate risk conditions would include Kawasaki disease, patients in whom they had coronary artery aneurysms that had already regressed, chronic inflammatory disease such as SLE, JIA, or rheumatoid arthritis, HIV infection, and nephrotic syndrome. Now, nephrotic syndrome falls under moderate risk because we do know that once a nephrotic syndrome is well controlled, the hyperlipidemia, the hypercholesterolemia does get mitigated with time. Then with this in mind, then what is the current framework for screening? Now, the screening for hyperlipidemia at current stage is still controversial. It's controversial because for many reasons, but these are based on the NHLBI recommendations and my personal practice, and not necessarily a reflection of the current recommendation that should be adopted globally. Now, for the first age group from birth to 2 years, no screening is required or recommended because of the variability in the diet. From the age 2 to 8 years, selective screening is recommended. Now, the selective screening meaning only for those who are at risk rather than universally screening them. From a selective screening perspective, what we do is a fasting lipid profile. Now, it is not the easiest to fast a young child, to be honest. So, but it is, if it is warranted, for example, if there is a family history of cardiovascular disease or family history of dyslipidemia of at least 240 milligram per deciliter or more than 6.2 millimoles per liter, or if there is a personal history, the patient himself or herself has high or moderate risk factors or high or moderate risk conditions. So if they have any of these conditions, then they should be screened. One of the things that, one of the downside of selective screening as such is that we do know that even in the absence of family history of cardiovascular disease or dyslipidemia, 30 to 60% of patients can still have dyslipidemia that may not be detected. So we would have missed 1/3 to 2/3 of these patients. And therefore, in the age group of 9 to 11 years, universal screening may be recommended. Now, there are some conflicting recommendations. For example, the US Preventive Services Task Force as well as the NHLBI recommend universal screening. But this approach is not necessarily a reflection of the approach of the AHA and the ACC. But personally, I think this would be prudent because this is the age group that we would want to catch the familial hypercholesterolemia such that we can do cascade screening, or we can even do reverse screening such that when the child or the proband is diagnosed, we can screen the parents who have never been tested. Now, the benefit of looking at the non-HDL cholesterol is that no fasting is required, because when we do a universal screening, to impose such fasting requirement on a large number of children in a population can be quite inconvenient. And we do know that we can look at a non-HDL component and we can disregard the LDL and the triglyceride when it is non-fasting. However, we would then have to move on to doing a fasting lipid profile if they are abnormal. Now, there is always this recommendation on an average of 2 sets. We need to do 2 at least 2 weeks apart, but no more than 3 months apart. Now, the reason for the repeat and an average of these 2 sets is to reduce the occurrence of false positive or the misclassification of dyslipidemia in these children. Now, if the non-HDL is more than 3.8 millimoles per deciliter with HDL that's less than 40, we should definitely do fasting lipid. However, if we started off by doing fasting lipid, then we should do another set so that we can get an average of 2. Remember, if it's fasting, then the LDL will be reliable, more than 3.4, non-HDL more than 3.8. The HDL, again, the cutoff is always less than 40 or less than 1 millimole. And then triglyceride is age dependent. If it is less than 10 years, then the cutoff is lower at 1.1. And if it is a child who is older than 10 years, then the cutoff is higher at 1.5. Now, again, one does not memorize this and is widely available in the document. So the NHLBI recommendation comes in 2 documents. One in a summary report published in Pediatrics in 2011, and there's a full report that's 200 over page long. Now, why is that an interesting group of 12 to 16? This is the age group in whom we expect puberty to occur. And we do know that puberty, it does cause a significant fluctuation in the cholesterols and lipid, and it can be as low 10 to 15% lower than what would be anticipated. And therefore, for this pubertal age group population, the recommendation is for selective screening. And again, it is a fasting lipid, an average of 2 sets again, provided there are cardiovascular risk factors in the family, or the presence of high total cholesterol in the family by more than 6.2 millimole per liter, or having a personal history of risk factors or medical conditions that predispose them to dyslipidemia or risk of atherosclerotic cardiovascular disease. And then when they pass on beyond the pubertal age group, from the age of 17 to 19, the recommendation therefore is for universal screening again. And this is the age group. Although from 9 to 11 years old, we want to catch them for familial hyperlipidemia, the 17 to 19 age group is an age group we want to catch before the lifestyle of an adult is ingrained and become irreversible. Now, we do know that in this age group, the neuroplasticity is still present, and we should be able then to implement changes that can last long in their life before they become an independent adult. And the cutoff are fairly similar to the universal screening as mentioned earlier on. And up to 21 years, when we call them young adult, the universal screening recommendation is still applicable with different cutoffs, because as they grow older, the cutoffs become that of adult cutoff values, and this can be referred to in the documents. Then we're going to talk about the management of and how do we approach pediatric hypercholesterolemia. Now, I'm not going to go through this entire algorithm again. For completeness sake, I've put it up here, and you can look at the document, the summary report published in Pediatric 2011. Now, suffice to say that if the triglyceride is more than 500 milligram per deciliter or more than 5.5 millimoles per liter, one should consult lipid specialist already or lipidologist. because this is a population who are at risk of acute pancreatitis. For those with LDL that are more than 250 or LDL more than 4.5, we should then send them to lipidologists rather than subjecting them down the lifestyle modification first, because the risk is of familial hypercholesterolemia is high. We want to intervene earlier or sooner rather than later. Now, once we implement all these lifestyle changes, including dietary changes, as well as implementation of physical activity. Now, the requirement for physical activity is actually quite stringent. Daily activity for at least 60 minutes of moderate to vigorous activities. Moderate to vigorous activity is defined as an activity that would induce, number one, breathlessness, such that the child would not be able to sing or make complete sentences, and the child would be feeling the palpitation from the tachycardia. So this is quite vigorous, and 3 times a week at least of this activity consisting of loading or resistance exercise. This is a high level of exercise to be implemented on a daily basis in order to achieve this target. We're not even talking about the dietary changes, and which is very complicated in terms of the percentage of fat, carbohydrate, and also protein, meaning lean proteins. But suffice to say, the principles apply in terms of increasing physical activities and healthier diet. And we then repeat the fasting lipid profile, and if they look okay, meaning within below the abnormal range, then we should be able to continue the lifestyle modification. If they are high, depending on how high they are, we further risk stratify them, and then consideration for treatment with drugs. Now, the commonest drug that is indicated or approved is the statin. The choice of statin is basically merely preference. I have a preference for atorvastatin. Some of my colleagues have preference for rosuvastatin, but we do know that simvastatin may not be as efficacious, but again, that is particular preference driven. Not to forget hypertriglyceridemia. In the most recent AHA scientific statement just released in February this year, we are looking at a triglyceride level of more than 2.26 in a setting of a non-HDL cholesterol of more than 3.8 millimoles per liter. Now again, same principle applies, looking for secondary causes, exercise, dietary changes before we talk about medications. Now I'd like to then show, does medication work? Now, at least in a population with familial, heterozygous familial hypercholesterolemia, implementation of statin treatment early has a significant lowering of LDL cholesterol, and not just the cholesterol level, it also reduces the atherosclerotic cardiovascular disease risk. As you can see here, based on this Kaplan-Meier curve that looks at the event-free survival from a cardiovascular event, you can see how the curves of their parents who were not treated diverged significantly, and the children who were treated did not develop significant cardiovascular event, even 30, 40 years after diagnosis. Now, if you look at death from cardiovascular causes, again, the Kaplan-Meier curve diverges quite significantly, proving that treatment, at least with treatment for hyperlipidemia, with a statin or otherwise, has a beneficial effect. And even if we look at the subclinical atherosclerosis, there is a slow progression or even reversibility. The good news is, fear not and fret not. There is reversibility if we treat either with statin or even lifestyle modification, as reports have shown. Now, we can initiate, the historical teaching is that we should initiate 10 years and above, but people have pushed it to as young as 8, and now first line for familial hypercholesterolemia, it has been approved to as low as 6 years. And combination therapy may be indicated if we are not able to meet the LDL target. Particularly for familial hypercholesterolemia, the target should be that of LDL below 3.5 millimoles or below 130 milligrams, and we should have at least a 50% reduction from pre-treatment levels. Now, why this is important in terms of meeting target goals? Because data have shown that there is a gap between the target goal as well as what is real in clinical practice. Now, this is data that's based on familial hypercholesterolemia registry studies in pediatric. And we noticed that children and adolescents are not reaching their LDL reduction goals. For example, 29% only at the point of entry into the registry with familial hypercholesterolemia diagnosed were on lipid-lowering therapy. Only 29% were treated despite the diagnosis of familial hypercholesterolemia, in whom we know that the risk of atherosclerotic cardiovascular disease is really high. And even for patients who are treated with lipid-lowering therapy, be it statin or otherwise, they are not reaching their LDL target goal. Only 23% reach the target of below 3.4. And the mean LDL in this registry was as high as 4.35 on statin monotherapy. And what it has shown that combination therapy works when we fail to achieve the target goals. Beyond just statin, there are many other drugs out there. For example, we do have bile salt sequestrants. We do have things like ezetimibe. But we do have newer drugs like PCSK9 inhibitor, which hitherto has been an injectable drug. There is now an oral version of PCSK9 inhibitor for which we are part of the global trial to prove its efficacy and its safety, and currently enrolling. Now, there has currently been no commercially available PCSK9 inhibitor, and this is one of the few medications that are on trial. So now, Dr. Juliet asked me this question about mandatory screening. I wouldn't use the word mandatory, but perhaps universal screening for hyperlipidemia. Now, evaluating this matrix on the criteria for screening, is this an important health problem? Atherosclerotic cardiovascular disease is one of the leading cause of mortality and morbidity in the world. And we do know that lipid is tracking from childhood into adulthood with direct causation of atherosclerosis. So this is checked. Is there acceptable treatment available? And the answer is a resounding yes, because lifestyle modification, be it diet or exercise, or be it drugs like statin, has been found to be safe and efficacious in children specifically. Do we have diagnosis and treatment facilities? Yes. Can it be recognizable in an early stage? And the answer is yes. We can do carotid intermediate thickness. We can do calcium scoring in a high-risk population. We can do endothelial function testing. Are there suitable tests or exam? Yes, but although it involves blood work. So sometimes getting blood from children involving a poke or venipuncture may not be the most pleasant thing, and a lot of negotiation, especially in the younger children, may be required. But one of the risks of doing this is that is it acceptable to the population, especially to the obese or the overweight children? For example, psychologically or from the mental health perspective, they have already been labeled as obese and overweight. Do they need another label that they are hyperlipidemic? But all in all, it is acceptable because it is a blood work, and we have done blood work for way lower indications. We do understand the natural history of hyperlipidemia, tracking from childhood into adulthood, causing atherosclerotic cardiovascular disease is well studied. And is there an agreed policy on treatment? There has been many publications and guidelines on the indication for treatment. Now, the next question here is it economically balanced? Now, this is something for the economists to do to evaluate the cost effectiveness or the cost utility of a universal screening. But I surmise that it is going to be very effective in the long run, because as the world population, especially in the developed country, continue to age more than some of these other countries in the world, as the world globally continues to age, we will spend more money dealing with complications of cardiovascular disease. So if we are able to prevent or delay them and giving them a better lifespan rather than health span rather than lifespan, this might just be another indication for us to implement universal screening. And it is something that we can do continuously, and the answer is again a resounding yes. And so it is of my own professional opinion that universal screening is warranted in the specific age group that I mentioned earlier on. To conclude, there are some key takeaways. The prevalence of hyperlipidemia may be underestimated across Asia Pacific because we are not testing as much as we should, and therefore we are under detecting. And those who are hyperlipidemic with normal body weight without risk factors, up to 30 to 60% of them are missed. Atherosclerosis, definitely, as the previous speakers have alluded to, begin in early life, and therefore prevention must begin early with a target as low as it is possible rather than definitive cutoffs. But it's easier when one has cutoff to work with. Familial hypercholesterolemia is definitely underdiagnosed, but it is imperative to diagnose them because they are highly treatable. Universal screening remains controversial. Depending on how you look at it, there are pros and there are cons. And high triglyceride, as well as in association with low HDL, is a pattern that is very common in metabolic dyslipidemia or insulin resistance, as the world continues to see and watch right before our eyes the epidemic and the scare of obesity, as the previous speaker has mentioned. I'd like to leave us with this, that early identification through screening and coupled with early intervention, and intervention can only be done with identification, would then amount to a lifetime benefit. With this, I thank you for your attention.
Thank you very much, Professor Chen. Another very comprehensive talk and excellent talk as well. Again, we are now proceeding to our open forum. Can we ask our 4 esteemed speakers to join us here in the Zoom page so that we can start our question and answer from our audience? Okay. Again, we have here the first question from our chat box. I think this question was addressed to Dr. Abad. How do we counsel obese children during practice?
That's a very tough question. So it really takes skill to counsel an obese obese patient, especially if the patient is an adolescent. We have this so-called motivational technique where we approach the patient on a positive note. We're not very judgmental. What I do personally is just I explain to them what their weight means. I show them the growth charts, and then I just tell them what are the possible consequences if they don't take care of their weight. And we use this, we share this 5210 rule. We always tell them that we don't really expect you to lose weight immediately, but at least to maintain your weight for the next 2 to 4 weeks. And we share with them the 5210 rule, the 5 servings of fruits and vegetables a day, not more than 2 hours of gadgets, 1 hour of exercise a day or physical activity, and 0 calories from drinks. More often than not, when the adolescent hears the two rule, where not more than 2 hours of gadgets and the 1 hour of physical activity a day, it seems that the world falls. But it's really more of pointing out to them what are the consequences of not losing weight. We have to be very patient. We explain to them that um, if during the next visit and they've done some physical exercise activities and they don't lose weight, we encourage them. We tell them that most likely the reason why you did not lose weight is that because of exercise, you already have built muscles, and that is responsible for the non-losing of your weight. So we use alternative measures like we measure their waist circumference so that during the next visit, and they've been adhering to this 52-10 rule, then that would be a better measure of response. However, it's really more of family approach because in practice, some mothers will bring their kids because of weight problem, but they themselves are heavy. So we always emphasize, we tell them that everybody in the family should change their eating habits. It's not only the patient, but because most of the time, almost about more than 50% of the family members have the same weight problem. It's really a very difficult issue. So we just tell them what are the effects. What are the sometimes of course we have to be very careful when we tell them what the consequences are. Personally, I just tell them that one of the things that they fear is injection. So I usually tell them, would you want to have insulin if you become diabetic? Do you want to inject? Although of course I know that injection is not the first strategy for type 2 diabetes, but the fear of injection is one weapon that I use, no? But it's really a family issue. Parang we shouldn't shame them. We just tell them why is there a need to lose weight. I think one of the things that I also try to elicit is that is she having problems with her friends? Is she having problem? You have to ask whether they have problem with their body image, no? Because if there's such a problem, I usually ask the help of an adolescent pediatrician to help out because you cannot spend a few minutes talking with these patients. You don't get across your idea in 10 to 15 minutes of meeting. So it is a continuous education. We just tell them what will be the bad effects if they don't lose weight. It's difficult, actually. That's why I usually refer them also to our adolescent pediatrician specialist. But again, as I mentioned before, it is important that from the beginning, from the first visit when they're still a baby, you really have to show them, you have to monitor the growth charts because in the Philippines, in our country, the grandparents would love to have a chubby grandchildren. And sometimes in the older age group, when they're about toddlers, they don't count milk as a source of calories. So you have to look into the dietary practices of these patients.
Okay, thank you. Okay, Dr. Abad, do you still have any thoughts?
No.
Come on. Thank you. I think for my next question, this will be addressed to Professor uh, Masood. This is in relation to hypertension.
I think he just left,
Just
Sheldon.
left.
We
Okay.
have him, yeah.
Okay, so anybody from our two cardiologists in attendance here? So Dr. Joni Bote as well as Professor Chen. So there's a question in the chat box regarding hypertension in children. This is a very common question in the clinics. Parents will ask that for how long should they be medicated? Is it for life or is it temporary? This question from Dr. Balderas. And ladies first, Dr. Joni.
Yes, thank you for that question. Actually, it's hard, but according to studies, ones on antihypertensive will always be on it. But then we cannot discount the importance of lifestyle modification, diet, exercise, massive education, to ensure that the risk factors will gradually reduce prior to the development of the actual cardiovascular disease. So the dictum really would be to identify early to prevent the risk factors from getting in so the disease will not develop. And if ever the patient already had risk factors, is to screen for hypertension, obesity, insulin, and then to ensure that the patient will not develop. But foremost is to start them off with a non-pharmacologic treatment, and if for several months there is no improvement, or the patient is symptomatic, then there's really need for medications.
Okay, thank you, Dr. Joni. Can we ask the thoughts of Professor Chen?
Thank you, Sheldon. But for sure, one has to be clear whether or not are we talking about primary or secondary hypertension. So I think if we are just focusing on primary hypertension or essential hypertension, and if we have really failed lifestyle modifications such that drug therapy is required, my usual spiel to the parents is give them a certain expectation that this is going to be very likely a long-term medication, because if they were not able to modify the lifestyle sufficiently in the 6 to 12 months, such that we would not need medical therapy, then why would it be successful until such a point in time that the child becomes an independent adult, and provided that he or she takes charge of his or her own life in such a way that the diet and the physical activity has been modified in such a way significantly that can mitigate the hypertension. So this is just purely from the perspective of essential hypertension or primary hypertension. Of course, if it is a secondary hypertension, then depending on what is the underlying etiology before we talk about the duration of treatment.
Okay, thank you very much, Professor Chen. Again, we have a follow-up question. This is in relation to treatment. So first question, from our chat box, which are the latest medication lineup for the familial hypercholesterolemia? And second, in relation to statins. So the question on statins, let me just read. Okay, so your thoughts on statins for children?
So from the perspective of familial hypercholesterolemia, let's just talk about the heterozygous familial hypercholesterolemia. The first, the most commonly used drug is still statins. And then with a progressive increment in the dose, usually 10 milligram per increment, up to 20-40 milligram once a day. If the drug is unable to bring it down to the target of below 3.4, then second line therapy or combination therapy may be needed. But the first line commonly is still the statin. As I mentioned, the choice of statin is usually preference. I prefer atorvastatin. I put all my transplant patients, as well as my Kawasaki disease patient with aneurysm with high lipid on atorvastatin. But it doesn't stop me from giving rosuvastatin, but I'm just more familiar with atorvastatin. The second line drug can be ezetimibe. I particularly like ezetimibe because it has been shown to be safer in children rather than the fenofibrate, which is not indicated or not safe in children. And of course, at the higher end, if patients cannot tolerate statin, then there are other options like PCSK9 inhibitor, which may be a bit more costlier.
Okay, thank you very much, Dr. Chen. So another question from the chat box. Supposedly this should be addressed to Professor Sadiq and Dr. Abad, but any of our cardiologists, esteemed speaker here, can also answer. So the question reads, in adults, most of the cutoff are based on incident cardiovascular diseases than non-STEMIs, that's STEMI and others. Is there already a longitudinal studies in children that monitored the occurrence of these cases, or the current cutoff more like mathematical model of adult population? Can we first ask Dr. Abad?
May I have that again?
This is in relation to the adult cutoff based on incident cardiovascular diseases So there is already a longitudinal studies is there a longitudinal studies in children that monitor the occurrence of these cases?
Unfortunately, no. Unfortunately, there are none at the moment. The only ongoing studies yet.
Yes. How about you, Professor Chen?
Yeah, right now we are still using the mathematical model based on extrapolation from adult studies, as I mentioned earlier on, to do longitudinal study long enough to track them from childhood all the way to that they are like 60, 70-year-old to develop atherosclerotic cardiovascular disease is going to be enormously long, but they are ongoing. So data would come and emerge at some point in time.
Okay, thank you very much. So another question, it was sent to me via Viber. This is a case scenario. Let me just read. So an obese adolescent, probably 10, 12 years old, with poor self-esteem because of the body image, weight image, and then diagnosed to have dyslipidemia, very high LDL, low HDL, and then positive HbA1c, and diagnosed as pre-diab or diab. And then your thoughts on aggressive management. This patient also had hypertension, and on 2D echo showed left ventricular hypertrophy. The question, your management, are we aggressive enough? How aggressive are we in treating this patient as a whole? There was a note on semaglutide and tirzepatide. Dr. Abad?
Well, how old is it? The tripartite is approved for adolescents above 12, but as pediatric endocrinologists, we usually start muna with the simplest, the metformin. We have this stepwise approach. We maximize metformin up to 2 grams. So if there's no significant change in the weight, the patient is diabetic, then we add insulin. Parang for me, use of trisapertide at the moment, I would be very cautious in using that. We use muna metformin, and then after 6 months, there's no change. After maximizing 2 grams of metformin, then add insulin. And if it doesn't work, then that's the time probably that I would try those newer designer drugs like your Ozempic and the Mounjaro.
Okay, thank you very much. So this is in relation to the diabetes as well as for obesity. We can actually, are you going to also recommend the two in controlling the blood sugar as well as obesity?
If the first two management do not work, as I said. But of course, it has to be in tandem. Because even if we use Ozempic or Mounjaro, if the patient's lifestyle does not change, then they may not work as expected.
Okay. From the cardiologist point of view, how are you going to manage the elevated LDLs, hypertension, LV hypertrophy? And this patient apparently is too lazy to exercise.
So from the outset, I think the hypertension associated with LVH, that's ominous, and therefore the systemic hypertension should be treated because regardless of the cutoff, if it is high enough that has caused LVH, it has to be there for long enough. So we need to make sure that before the child develops a heart failure or incremental risk of CVD, we should treat the hypertension. When it comes to the lipid, now then one has to be cautious. We end up having a polypharmacy in a child in this manner. So, for example, if Dr. Abad is going to say, let's give a GLP-1 agonist, then it's going to solve, for example, hypothetically speaking, if one is going to give a GLP-1 agonist, it's going to solve the diet intake, the weight, and then it will solve the diabetic issue, be it Ozempic or Mounjaro, and depending on whichever brand that you use. So that might work. But as Dr. Abad pointed out, it has to be, if he's too lazy to exercise, then we really need to institute some form of cardiac rehabilitation, because the moment the drug is seized, and this is well documented, the rebound effect is way worse than what the child would have started off with. So that's the danger if we do not have a parallel lifestyle modification.
Dr. Joni, your thoughts on this daunting case?
Yes, I agree that once there is already target organ damage, we might really need to consider pharmacologic treatment. But for in terms of the aggressiveness, the aggressiveness in adult is different from the perceived aggressiveness in children. So still part of the aggressive treatment. I agree that with that case, there should be aggressive treatment, but aggressive treatment is not solely pharmacologic. We still go by the non-pharmacologic, which is education, lifestyle, avoid sedentary behavior, things like that. And then foremost is to address the psychological or the depression of the patient, because if the patient is depressed, no matter how much you talk to them, they will only remember a few. So we should aim for a positive outlook in life, as a good self-esteem. So, and then we educate, and then if ever non-pharma, we need to do pharmacologic, then probably this will be better. This will be taken well by the patient. And probably towards the end, success in whatever management we give will be seen.
Yes, I think that's a very good suggestion. But rather, would you rather also educate the parents or the whole family?
Yes. If you, Dr. Abad mentioned earlier that it should be family-centered. The treatment or the way we give advice to these kids is not really patient alone-centered. It should be family-centered. Can you imagine asking the patient to avoid having sugary drinks, and yet in the family there are soft drinks, there are sugared beverages. So the family should be with the patient, should be with the protocol that you will be giving the patient. For example, low sugar, high water, physical activity. The trajectory or the experience of the patient will be better, will be happier if it is shared between family members.
Okay, thank you very much to our esteemed speaker in attendance here. So unfortunately, Dr. Sadiq already left. But in the since we are already overdue, so I think we now proceed to our closing remark. Can we ask Professor Kankanarachi for the closing remarks?
Yeah, thank you. First of all, I would like to thank Dr. Jocelyn Isibo, the president of Asia Pacific Pediatric Association, for organizing this important webinar, and also Dr. Sheldon Paragas for the moderating session. And also, I would like to extend my sincere appreciation to all the speakers, Dr. Johnny Boyd, Professor Lorna, and Dr. Mazood, and Professor Chen Ching, for your valuable contribution and insightful presentations. And finally, I would like to take this as an opportunity to invite all of you to participate in the 19th Asia Pacific Congress of Pediatrics, which will be held in Sri Lanka from 27th to 30th of July 2026. And we have extended the early bird registration till 31st of May 2026. And thank you for everyone, those who have joined this webinar, and I wish you all a pleasant evening. Thank you.
Before we will close, can we ask Carl, do we have the QR code for the certificate of attendance
Yes,
for our participants?
And also a picture taking, Sheldon. Yeah.
And also before we will forget, so again, the post evaluation QR code now posted in our screen, so you may start to answer the post evaluation form in order for you to get attendance. And while doing so, let us all open our camera for the mandatory picture taking.
So this is Dr. Balderas. Juliet, can you speak a little bit? Yeah, the president of the Philippine Society of Pediatric Cardiology. Juliet. Can you unmute Juliet? Carl?
I'm here, ma'am.
Okay. Say hi.
Hi to everybody. Thank you for attending. It was
Thank
really
you
a
very much. And Professor Iqbal, the immediate past president of APPA. So once again, thank you very much.
Yes, thank you very much.
We will have a picture.
Excellent program.
Thank you. Let's have a picture. 1, 2. Everybody look. 10 pages. 1, 2, 3. Please stay with your smiles. Five pages more. Wow. Well attended.
Very well attended. Very well.
Yeah. Thank you very much.
Extended and attended.
2 more.